Good evening, everybody. My name is Dr. Musa Akbar. I'm really honored to participate in this meeting. My talk today will be heart failure across all ejection fraction, with focus on the latest presentation from European Society of Cardiology 2021 on the Emperor Preserved. These are my disclosure. So the Emperor Preserved presented in the last European Society Cardiology meeting 2021, and the Empower program milestone for improving cardiovascular outcome has started from 2015 on the EMPERIC outcome, where the drug empagliflozin showed an effect on cardiovascular morbidity and mortality in patient type 2 diabetes. In 2020, there was a announcing of the Emperor reduced for the effect on hospitalization of heart failure in diabetic and non-diabetic. And now we are glad to have the data from the Emperor Preserve presented in 2021. And upcoming, there is an impulse using of empagliflozin in acute decompensated heart failure, and finally using the drug on post-MI, and this is also an upcoming trial. The new universal definition of heart failure classifies the different heart failure according to ejection fraction. Of those less than or equal 40 is the heart failure with reduced ejection fraction. More than 50%, equal or more than 50% heart failure with preserved ejection fraction, and in between 41 to 49 is heart failure with mildly reduced ejection fraction. Please note that if there is an if the baseline of heart ejection fraction less than 40 and there is improved more than 10-point increase, it is called heart failure with improved ejection fraction. And the measurement of ejection fraction should be equal more than 40%. We know very well from the epidemiological data that the patients with heart failure with preserved ejection fraction, the HFPEF, suffer from poor outcome. And more than 50% of patients with heart failure suffer from HFPEF, and this proportion is significantly increasing, and approximately 30% of patients with HFPEF die within 1 year of hospitalization of heart failure. Before presenting to today data, there's no clinically proven therapies are available to reduce heart failure outcomes, and the treatment options are limited to the symptoms control and treatment of comorbidity. This is the design, ladies and gentlemen, for the Emperor Preserved study. It's a phase 3 trial in patients with HFPEF, taking ejection fraction more than 40 in type 2 diabetes and no type 2 diabetes, chronic heart failure with NIHA class between 2 to 4, giving 10 milligram once a day of empagliflozin versus placebo, with median follow-up is 26.2 months. There are 3 endpoints. One is the composite primary endpoint, which is time to first event of adjudicated cardiovascular death or adjudicated hospitalization of heart failure. And the 2 key secondary endpoints, they are confirmatory secondary endpoint. The first one is the first and recurrent adjudicated hospitalization for heart failure. And the second one is the slope of change in glomerular filtration rate from the baseline. These are the major inclusion and exclusion criteria. Of note, the main exclusion criteria is the acute decompensated heart failure being excluded, and the glomerular filtration rate more than 20 or requiring dialysis also being excluded from this trial. The baseline characteristics, majority are in class 2, 81%. For the ejection fraction from 40 to less than 450, there is 1/3 almost. and from 50 to 60% is another third, and more than 60% is another or third. And that making more than 2/3 of the patients in the Emperor Preserve had an ejection fraction more or equal than 50%. The main results, ladies and gentlemen, that the empagliflozin demonstrated a clinically meaningful 21% relative risk reduction in the composite endpoint of cardiovascular death or hospitalization for heart failure, with absolute risk reduction 3.3%. Number needed is 31. And you can see that there is a separation of the curve earlier in the course of the treatment, and the curve continued to diverge throughout the period of the study, and the p-value is highly statistically significant. The pre-specified group has been found that there is a consistent, clinically meaningful across these pre-specified, and overall age, whether less than 70, more than 30 benefited from the treatment group. Male or female are benefited from the treatment group, as well as those who have ejection fraction less than 50 to 60, and more than 60 are benefited from the group as overall. And this pre-specified subgroup showing a benefit with the p interaction is not significant. And whether you have diabetes or no diabetes, they have benefited from the treatment group. Renal function more than 60 or lower than 60 is also showing benefit from the treatment group. And ischemic and non-ischemic etiology of heart failure showing benefit. More benefit was observed in non-ischemic etiology, and whether heart failure hospitalization in less than 1 or equal 1 year, yes or no, also showing a benefit from the treatment group. And also overall there is a benefit from the following pre-specified subgroup, whether the baseline ACE or ARBs or ARNI showing a benefit, or mineralocorticoid antagonists, there are benefit, or lowering the anti-brain natriuretic peptide, whether below median, high or higher than median, there is a benefit. Whether you have hypertension and no hypertension, there is a benefit, or history of atrial fibrillation or atrial flutter, there is also benefit. Now, the empagliflozin reduced the first and recurrent hospitalization of heart failure by 27% in the confirmatory endpoint. Again, very highly statistical significant of p-value, with notice of early separation of the curve through the earlier study out period, and continue to diverge the curve throughout the period of the study. For the second confirmatory endpoint, the empagliflozin protected the kidney from significantly slowing the decline in kidney function. As you can see, there is a protective effect. The difference in decline is 1.36, and that is significant p-value. With empagliflozin, the drop per year 1.25, in the placebo 2.65, making that the rate of the glomerular filtration rate decline in patient treated with empagliflozin, was half that of patient treated with a placebo, giving the renal protection of the drug. And this is similar data that was presented with Emperor reduced. So, ladies and gentlemen, the Emperor preserved the specific endpoint for hierarchical testing. All showed confirmatory, the primary endpoint, adjudicated cardiovascular death or hospitalization for heart failure, 21 relative risk reduction with significant p-value. The secondary endpoint, adjudicated first and recurrent hospitalization for heart failure, is confirmatory with with a 27% relative risk reduction with significant p-value. And the last of the secondary endpoint is the glomerular filtration slope decline is confirmatory, with the difference is 1.36, giving the significant P, giving the renal protection and the slowing the decline in renal function with the treatment of empagliflozin. For the exploratory endpoints, the composite endpoint of the primary endpoint, the hospitalization of heart failure and cardiovascular death, was mainly driven by the hospitalization of heart failure. And the other pre-specified outcomes, the change in the Kansas cardiomyopathy score was slightly better in the treatment group. The all causes mortality show no difference between endpoint as well as the composite and renal endpoint were similar in both groups. For the changes in vital signs and laboratory findings, the glycated hemoglobin was less in the treatment group compared to the placebo group. Hematocrit was more in the treatment group compared to the placebo, as well as the body weight was more or less in the treatment group than in the placebo. Systolic blood pressure, more drop in the in treatment group versus the placebo. Uric acid more lower in the treatment group than the placebo, as well as the N-terminal pro-brain-natriuretic peptide more lower in the treatment group compared with the placebo. For the safety outcome, ladies and gentlemen, any adverse effect, as you can see, are comparable between the treatment group and the placebo, as well as the serious side effects. For the hypotension, symptomatic hypotension are more comparable, are comparable in the treatment group as compared to placebo, similar, as well as the complicated UTI and complicated genital infections are comparable between two groups, as well as the ketoacidosis and hypoglycemic effects were similar in treatment group and placebo. And even in patients without diabetes, there is no fear of ketoacidosis or hypoglycemic events. These are comparable between the treatment group and placebo, confirming the safety profile of drug in this type of population. So to summarize, ladies and gentlemen, the results from Emperor Preserve, the half of all HFpEF patients have HFpEF and suffer from poor cardiorenal outcome despite optimizing symptom control and treatment comorbidities due to the absence of any clinical proven therapies today. With the Emperor Preserved for the first time in medical history, our treatment showing beneficial outcomes in patients with HFpEF by reducing the risk of the composite endpoint of hospitalization of heart failure or cardiovascular death. Empagliflozin demonstrated a clinically meaningful 21% relative risk reduction in the primary endpoint of cardiovascular death or hospitalization of heart failure on the top of the background therapy. The benefit was independent of ejection fraction and consistent across the further pre-specified subgroups. In addition, empagliflozin reduced the first and recurrent hospitalization for heart failure by 27% in a confirmatory secondary endpoint. And the empagliflozin protected the kidney by significantly slowing the decline in kidney function. The overall safety data were consistent with the previous finding in cardiovascular patients, confirming the proven safety profile of empagliflozin. Empagliflozin is already indicated to treat patients with heart failure with reduced ejection fraction with a proven risk reduction of cardiovascular death or heart failure. Now they extended to preserve the ejection fraction. And if proved for treatment for HFPEF, empagliflozin would change clinical practice by becoming the first and the only therapy to improve cardiorenal outcomes for the full spectrum of heart failure patients, regardless of ejection fraction. Reminding you that this trial, the Emperor Preserve, is published simultaneously in the New England Journal of Medicine in August 27, 2021. And also FDA grants the empagliflozin breakthrough therapy designation for heart failure with a preserved ejection fraction, waiting for the final approval. By this, I end up my talk, and thank you very much for your attention.